Let's take a look at the Emergent module. This is a review. The drug of choice for cardiogenic shock is going to be nitrates, nitroglycerin, or nipride. They are vasodilators. We want to open the vessels so that we can make sure that blood flow is happening with cardiogenic shock, because part of the problem is in cardiogenic shock, the pump, the mechanism, the pump itself is not working. It's not working correctly. And so we need to make sure things keep moving through. One of the biggest causes for cardiogenic shock is acute MIs. So if we have an acute MI, what do we know? There's a blockage, right? We need to dilate out those vessels, get the blood flowing. Also, always remember to keep a watch on your blood pressure, because nitrates will bottom your blood pressure out if you're not careful. And it's a systemic vasodilator. So you're going to have a headache. They're going to feel like they've got a headache. And that is just part of the drug. But the drug does work, and it is something that we want to use in an emergent situation. Neurogenic shock, always think bradycardia with neurogenic shock. So it was brought to my attention, wonder if you fall and you have a big gash and you're losing blood, but you've also had a spinal cord injury. Well, in that case, you're probably going to have shock, period. So you're dealing with hypovolemic shock, you're dealing with neurogenic shock. But just so you know, if you've got a neuro insult, then you're going to look, and one of the big indicators for neurogenic shock is bradycardia. And that means you're going to have to use other drugs. And that will be another slide here coming soon, and I'll talk about it. Cushing's Triad, what is it? Well, when you have neurogenic shock, you can have Cushing's Triad. That's hypotension, bradycardia, and hypothermia, or their hypothermic patient or client. So that is something to understand. If you're hypotensive, bradycardic, and hypothermic, that's a bad sign. That is a major, it's neurogenic shock, major spinal cord injury. So it's very important that you understand that, and that's what that's called. So if you ever hear, it's a Cushing's Triad, that's what you're looking at. What is the problem in cardiogenic shock? Well, I just said it a few minutes ago. It's the pump, or the mechanical part of the heart. It is not the electrical part of the heart. So if you did an EKG, unless they're having arrhythmias, which is a possibility when you're in cardiogenic shock, but when you are hooked to an EKG, the EKG is going to read whatever you see. It's not going to be anything different electrically. It's not interfering with any electroactivity within the heart. It is dealing with the pump or the mechanism of the heart, the actual muscle of the heart. That's when you see cardiogenic shock. If I use epinephrine for anaphylactic shock, what drug is used for neurogenic shock? Well, we know we use epinephrine for anaphylactic shock. We also use epinephrine when it comes to other shocks, if we need to. But the drug of choice is usually vasopressors. And in the vasopressor world, you are going to see the dopamines, all of the inotropes. Those are vasopressors. We're starting to actually really utilize those drugs during these times, because we need to do what? We are trying to, just like what a vasopressor says, tighten up those vessels. And there's a reason for that. Because when we're in neurogenic shock, we're going to lose tone and resistance due to the mechanism of injury, the injury, neuroinjury. Epinephrine can be considered a vasopressor, but when we use epinephrine for anaphylaxis, we're using a specific dose that isn't a vasopressor. It's instead working with that whole antihistamine release. So that's the difference. When we use epinephrine as a vasopressor, we're going to use that cardiac dose. And I talk about that in one of my slides, the differences between the anaphylactic dose and the cardiac dose. And it's the same drug. It just is that drug will do this at this dose and rate for a child or an adult if they're in anaphylaxis. And if they're in a cardiac or a neurogenic world, you can use epinephrine to help vasopress, depending on the amount of drug you use. So, but for testing purposes and in your thought process, if you have a neurogenic drug of choice and the choices are out there of whatever's out there, I want you to choose vasopressor. Vasopressors. Really quickly back to the vasopressor. And by saying that, it's a broad spectrum. So you want to use vasopressors with neurogenic shock. We don't always use pressors and drugs like that in cardiogenic shock. We don't have to. If we go to use those with cardiogenic shock or septic shock, you know, the other things are going on and we're needing to use it at this point. But for neurogenic shock, I want to reiterate this. What happens is you have that neuroinsult, you lose the tone of resistance to your blood vessels, so you can't support a heart rate, you can't support a blood pressure. So the drug of choice, the first line of drugs is vasopressors for neurogenic shock. Hope that's clear. Parkland Formula, it's spelled out. I have a big lecture on it, but it's when you're doing the actual math, you've already done your rule of nines on the burn. You've taken the rule of nines, estimated the percent of the burn, and then it is 4 times whatever the body weight is in kilograms times that number that you get when you do the rule of nines, which is the percent of the burn. So don't worry about putting a milliliter and a kilogram or a percent behind those numbers. Just make sure you have 4 times whatever the body weight number is times whatever the number is for the percent of the burn. Once you multiply that out, starting from left, go across to right, you will get a very large number. That is the amount of fluid that needs to be given to resuscitate for hypovolemia or volume loss for burns, for hypovolemic shock for burn patients. So they don't go into hypovolemic shock. So we're going to take that number, divide it in half, give the first 50% in 8 hours from the time of the injury or the burn, from the very time that the burn happens. So one of the biggest questions or the best questions to ask EMS who brings the client into the hospital or clinic setting is to say, what time did this burn occur? So that you can start thinking your fluid resuscitation from that time that is given, not the time they enter the hospital. And then you're going to give the second 50% in 16 hours. If my vessel tightens when I lose volume, what do my vessels do if I have a spinal cord injury? I've already said that. I want to reiterate that. And I want to really push that because that is one of the biggest difference with neurogenic shock is the patient or client will lose resistance and tone. So that's why we want to use vasopressors. First line of drug for neurogenic shock, vasopressors. First line of drug for cardiogenic shock is nitrates. First line of drug for hypovolemic shock is volume. Because we all know that normal saline, any of the volumes that we give are considered a medication or a drug. So we give that. If you lose blood, you give blood. So while I'm waiting, I'm giving something because I can't just sit there and dilly-dally while their blood pressure circles down to nothing. So I'm going to be giving that normal saline wide open, or I'll be giving, a volume expander if I can, and that while I'm waiting for blood to come. If I have a patient that is bleeding at this point, this is not mass casualties, I'm just talking back about hypovolemic shock really quickly. If I have a patient that's bleeding, then I know that I need to give blood. But if they're bleeding large amounts of blood and it is necessary to get blood quickly, we will get uncrossed or unmatched blood, O negative. We're going to hang it, give it quickly. And then we will have already sent off to be typing and cross-matching our client or our patient so that we can get their specific blood, their specific type and screen to them. But if it's an emergency and we need to just go, we go with O negative. MASH casualty clients will be triaged. Black tag, imminent death. Red tag, life-threatening injuries and needs immediate attention. Green or white, you will see sometimes green, sometimes white, depending. They are walking and they are talking. They do not need any kind of care. You will also see yellow tags, and I'm going to show you this little algorithm, and yellow is involved with it. And the yellow tag, if the client, if you follow your algorithm on this, and there's different algorithms out there, but I like this one, it's kind of simple and it breaks it down quickly. If the patient's walking and you say, yes, they're green. Green is there's no issue, immediate treatment needed before others. So they kind of go over to an area. They might have a cut or something, but they're not bleeding out. It's just something minor. They can be holding a little gauze on it while they wait to be treated. If the patient is not walking, then you're going to assess the breathing. Are they breathing? If they're breathing, you're going to then go into, are they in shock or actively dying, but probably savable? Are they salvageable? If that's the case, then you're going to red tag them and work them. If it's a no and they're not breathing, you're going to reposition the airway with a jaw thrust because we don't want to tilt the head back because we don't know if there's a spinal cord injury. And we're going to then stimulate the patient to see if we can make them take a breath. You know, hey, wake up. Are you breathing? Are you breathing? Reposition airway. And then we're going to see if they're breathing. If it is a no, they are black tagged and no further treatment is necessary, meaning it's imminent death. If there's imminent death, you can give them pain medicine for comfort. You would never want someone to lay there that's awake and dying to be awake and dying. So if you want to give them and you have the ability to give them pain medicine or medicine for comfort, you are usually through a protocol given the opportunity to treat that patient with medicine for that. Everybody else gets treated per protocol for what is going on. If they're red tagged, they're coded, you would use them per an ACLS protocol, those kind of things. So it is protocol driven. But you can, if they're black tagged and dying, you can give them something for comfort, FYI. Debriefing. Why do we debrief? To help with post-traumatic stress. It is stressful to go through as a client or as a person, as a client patient. It is stressful, of course, because it's on their body, they're going through it. But as a caregiver, it is so stressful. So why do we debrief post a huge mass casualty or a big something that happens within the hospital and there's a lot of death or anything major? The reason why we debrief is to hopefully help with post-traumatic stress. We don't want people to have PTSD based on working and caring for clients that have mass casualties and situations that they've been put in that can create a huge, huge stressful insult to the mind, soul, spirit, body. So that's why we debrief. It's not to say, hey, did we do a good job? Hey, did we not do a good job? It's, did we do a bad job? You know, it's not that. That's a different kind. People will call that debriefing. But for mass casualties, for major issues going on where you've had to work with patients, a lot of bad things have happened, debriefing's used for post-traumatic stress to hopefully prevent it. What range should arterial blood gas be? In a PaO2. Now, in our PaO2, 80 to 100 is what you had listed. I will actually post this up. It'll say 88 to 100. If you get below 88, there are issues happening. You are already working against the clock of turning it around. So we'd love for them to stay in a range of 88 to 100. If you are testing and they ask for what are the normal PaO2, you're going to say 80 to 100. But what range should your arterial blood gas be in? Between 88 and 100. So when you read that, you're going to go, well, I learned last semester it's 80 to 100, and you did, and that is correct. If you're being tested for what a true lab value is, 80 to 100 is where your PaO2 range is. Anything below that is death. Anything above that, there is nothing above that, because 100 is the best. So if you are at 88 and you're at 87 and you're trending down, we're looking at numbers trending, remember. If that's the case, if you've not already started to intervene with oxygen and other supplemental things to start to turn this patient around, you are looking at a patient that is going to be shocky and that is going to have imminent death, because you're going to start to not be able to perfuse the tissue. And you don't have to be at 80 for that to happen. It starts under 88 to slowly start happening, and it's a snowball effect. So remember the bell curve. There's a bell curve, and at the top of the hill, if I'm on my bicycle, that's 100%. If I go to 90, I'm still kind of on the top of the hill. I'm just slowly starting to pedal, and I'm doing okay. If I get to 88, I've come off the top of that hill, and I can tell you that from that point going, it's going to be a fast downhill on that bike. I'm just going to pick up speed rapidly. And that's how I want you to critically think. So if I look at an 88 on a PaO2, I'm going to go, this isn't good. Or if I look at an 88 on a SAT, on an SaO2, that's not good. I need to be doing something immediately to start to turn things around. Because if not, I'm getting to the part of the hill where I can't turn it around. I'm going to go straight down fast. And when I get to the bottom, I'll have to deal with whatever. So that's how I want you to think. Okay. Isolation, just review your isolations. Just remember, reverse isolation is neutropenic. So it is reverse. I want you to think of that. When you think neutropenic, think reverse. That's the client or patient that has a compromised immune system. So what has to happen is you're dressing down to protect them. You're not dressing down to protect you and others outside of the room. Instead, you're dressing everybody down outside to protect the person inside the room. So go through those precautions, because one of the things that you need to think about is with airborne or droplet precautions is you're looking at bioterrorism issues, right? So we want to think of what can travel in the air as something that people want to use for bioterrorism, because if they can drop that out and it hits the current of the air, then a lot of mass people can breathe it in. So that's why you'll see measles and things like that. But think about COVID-19. I mean, I'm not saying that is bioterrorism, but I'm just saying that is definitely something we need to make sure that we understand how to put our proper PPE on and how to handle that. So go through those things, refreshing your memory of all your precautions and germs that you use for those. What is standard? Well, that's everybody. We consider everybody's body fluids to be possible infectious. So we wear gloves, right? We wash our hands. We wear gowns so that it doesn't splash on us. Airborne, we need to dress it down, and we use N95s. We use different type of breathing devices. We use hazmat suits if necessary. Contact, we're going to wear gloves. We're going to make sure that we have our mask on. We're going to make sure that anything that's making contact with anything that it can lie on the surface that we have covered. So look back at germs and where we use that. Neutropenic, we know it's people that usually have had chemotherapy, or if they have a disease process that suppresses their immune system, we would want to use reverse or neutropenic. So go back through and review that. You might have to go into other units, but you need to find that. You're going to see this on your NCLEX. It's something you need to understand for your own protection too. A patient is hit with a sledgehammer to the left leg. He's holding his thigh and hip. What shock would you or could you suspect? Hypovolemic. It's hypovolemic, large bone involvement, femurs, pelvic girdles. They can lose 300 to 500 mLs of blood when fractured. It's important to know. So if you have a big, large femur fracture, it's enclosed, it's not a compound fracture, the bone's not sticking out anywhere where blood can come out, so you're not visually seeing the blood, you're going to see the thigh enlarge, you're going to see it get mottled in color, and it's going to bruise and be very tender, because blood inside makes the patient very nauseous, very tender to touch, and they hurt very badly. So if you have an abdominal bleed, that, anything internal, it's going to have that look, that consistency, and it can, if it keeps filling, it'll become hard, because the body, it's like a balloon filling up with water. Eventually, it's going to have so much in there that's going to be, the tension on that skin is going to make it feel hard to touch. But if it's that full, you're in trouble. But I want you to think about how much blood is in a unit of blood. It's approximately 320. It can be a little more, a little less, whatever, but it's around in that world. If that's the case, and you can lose 300 to 500 milliliters of blood with a fractured femur or pelvic girdle, sorry, I can't get it out, pelvic girdle, then you have lost a unit of blood. So it is so important that with these large bone involvement fractures, that we get them to surgery. That's how you have to correct that. We also want to get blood type cross-matched and hanging if needed quickly, so that they are getting blood replaced. If they're bleeding so quickly and they're hypotensive, they're pale, diaphoretic, they look just bad, you might want to go ahead and order O negative blood to be hanging as you're going into the OR. And that would be a protocol or physician driven order. When a large bone breaks, there's bleeding and swelling, just FYI. What do you always check when there's a broken bone or joint injury? You always want to check a pulse. No pulse, no perfusion to the affected area. So it's always a distal pulse. So if I have a broken arm, upper arm, I want to make sure that I check my radial pulse. If I have a broken forearm, I want to check my radial pulse. If I have a broken leg, femur, any kind of broken bone, I would go down and check a pedal pulse, because I want to make sure that blood is flowing properly. Because if I don't have blood flowing, I don't have perfusion. I don't have perfusion, I will have death of tissue. It's not getting oxygenated blood. It's just so important. Burns. This is a little chart. They change different from book to book. But what I really want you to understand about burns is that first degree burn is that red. You can have a little bit of pain, a little bit of swelling. That's your sunburns, those little burns. A little teeny quick burn that you get from maybe a little steam, and it's very fast. It gets red. It's gone by the next day. Those are the superficial first degree burns. When you get to second, third, and full or fourth degree burns, those are the burns where we have blisters and splotchiness, but there's swelling and it hurts for second degree. Third degree, they're going to start to get where it's not as painful, because you're getting down into nerve endings. And when you get to full, you are charred. It is eschar, that black, leathery, insensate. You can't feel, because you have burned all of the nerve endings in that area of the skin. So you could touch that burn and it's not going to hurt them. Now, you don't want to be touching it, but I'm just saying they're not going to feel things. So if you have those burns, the second, third, or fourth, or full degree, full thickness, then what happens is I want you to understand that everything with a burn should be sterile. You want sterile sheets. You want sterile drapes over the patient. You want to get all the clothing off, remove it. All jewelry comes off first because of the swelling. If there's a necklace and they were burned, it needs to come off. If there's a ring and it's burned, it needs to come off. Get the clothing off. It'll be wet and moist. You don't want to put, if they're leaking or seeping a lot of volume out of their burn, you don't want to just put dry gauze on that, right? Because what's going to happen? You do want to moisten it, and to moisten or wet it or dampen it, you would want to use sterile water or sterile water to put on that, so that it keeps it moist and nothing sticks to it. The ticket is to keep things from sticking to the burns. You don't want it to stick to the burn, and what you want to do is just keep it just good and sterile. So with that, just remember, a burn patient comes in, you want to assess them quickly. You want to look with your pen light up into the nares. Is there black soot? Do you see anything up there? Look in their mouth. Is there burns? Do you see redness? Do you see blackness? Anything like that, you're going to think airway has been involved. If that's the case, then the protocol normally is we're going to go ahead and intubate you, sedate you and intubate you so that we can maintain an airway. Because our fear is once the swelling starts, once the volume starts to shift, you will not be able to access that airway. You can shut their airway off. So it's so vitally important with burns, take them very seriously and go ahead and assess. It might not look bad. I have a picture in my lecture of a gentleman, and he had a whole facial where it splashed up and burned his face. And within 24 hours, you can't recognize him. He is so swollen. So it is so important that you understand that. So the main thing for burns that I want you to know is remove all jewelry immediately, because they become tourniquets and clothing needs to come off. You need to use sterility for everything, including what they're laying on and being covered with. And it is hypovolemic shock. So we use the rule of nines to go ahead and assess the percentage of the burn. And then we use the Parkland formula to calculate how much volume we're going to replace to this patient. And it starts from the time of the burn. What agency is responsible for emergency plans? Hint, only for accredited hospitals. So the Joint Commission comes in and gives accreditation to hospitals. If there is an accredited hospital, the agency will, is responsible or assists the hospitals with their emergency plans. There's plans put in place. So as a nurse, the chapter is interesting to read, but as a nurse actually practically working while you're out there, you're not going to be getting the notebook or looking something up online and going, okay, I'm going to do this and this. There is a protocol that goes into place, and there are people who work certain positions that make those decisions, and they are even outside of the hospital or clinic facility. So what happens is you would report to your clinical manager if ever there's an emergency and you need to use emergency plans, if a mass casualty or a bioterrorist attack, you would find you're called, it goes over the intercom system. You would then report immediately to your manager. The manager at that point will roll out the plan for her area. Some of you will need to report to the ER. Some will stay up and get ready to accept patients. It just depends. Some people will be moving patients off the floors, getting things ready. Everybody has a role, but your role will be given to you when this time comes, and it will be discussed with you through your manager, who goes by the plan, who goes by the hospital, people that are in charge of all of this. ER is the contact point, but the outside, there's people that go to college to learn how to establish emergency plans and do this. A perfect example is when we had 911. And when that happened, that's when the intercom systems throughout emergency services, hospitals, all of that was relooked at, because we needed things to work as a unit. Everything has to, because we have to, if we don't work together, it just becomes chaos. So, but off target with that, back to Joint Commission. Joint Commission is the agency responsible for emergency plans. Yay. Joint Commission. A, B, C, D, E. A is for airway, B is for breathing, C is for circulation, D is for disability, E is for expose. Don't get all the, you have a gunshot wound over on the side, front, lower abdomen, and, it's grazed them, but it's opened it up enough. There's blood, there's some tissue hanging out, and it's pretty gruesome looking. And you get so fixated on that you forget to take off any other clothes, turn the patient over, take a look at everything from top to bottom. And what you forgot to see or didn't see, you didn't forget, you didn't see because you didn't expose them and turn them, is that they had been stabbed 10 times in the back, and it's compromised their airway. And F is finished this semester. Yay, we're almost there, guys. Okay, it's hard to read this, so I'll just read. A large truck with an unknown chemical explodes on the highway and a bicycle races in the area. Approximately 50 people are covered with this chemical. What should the hospital and nursing staff prepare to do first? The answer is decontaminate. If you allow a contaminated chemical or substance, contaminated clients or patients to enter in through the ER doors or into the hospital itself anywhere, you have then contaminated the hospital or the clinic setting. So instead, what you want to do is set up for decontamination. And that is all down in the ER. They know what to do. They will then set that up. It's outside. And what you're going to do is take off all clothes immediately, cleanse the skin with large amounts of soap and water. Now, it is vitally important, this very general, is vitally important that you identify the chemical as soon as possible. People will be working on that, but it is something you should question as a nurse. You should say, what is this chemical? Because you also will need to be in hazmat clothes protecting you from the chemical as you're decontaminating. The other thing is with this, the thought is there are different chemicals out there that when you add water to them, they can be more toxic or have more, become chemically, imbalanced. And if that's the case, then we want to make sure that we understand. But if in general, and you don't know, they're covered with a chemical, you need to just cleanse them and scrub it off as fast as you can with soap and water. And the reason why is we're trying to prevent any further injury from the chemical, any further chemical burn. If a chemical disaster happens, what do? This is talking about what do you do at home? What would you want to tell patients or clients, or what do you want to understand? That if there is a chemical disaster, you hear that horrible sound come over the television or your telephone, and all of a sudden there's a chemical disaster 2 miles from your home. What are you going to do? First of all, you want to close it, get all good air, which is inside your house, to stay inside your house. And you want all bad air to stay outside your house. So you're going to close your windows. You're going to turn off all your fans, heaters, and air conditioners, close the fireplace damper if you have one, and you're going to stay inside. This is not a TikTok moment. It's not time to go out there and video yourself saying, look at this, yay. No, it's time to stay inside, seal down everything you possibly can to keep the good air in and bad air out. Here you are. Keep the bad air out. Keep the bad air out. A tornado has been spotted on the hospital, and the hospital activates a code Toro. Now, I'm just going on record to say that everybody's codes are different for different hospitals. The hospital that I worked at, code Toro was our tornado. So if we had a code Toro come across, then we knew there was a tornado that had either touched down in the area or was spotted, meaning it's time that we need to do some major stuff quickly. So what should we do as the nurse? We will make sure all our guests remain in the hospital and do not leave. We will make sure to close the blinds or curtains, and we'll protect them from all flying debris. If you can move the patients or clients into the hallways, out from the rooms and into the hallways, and close the doors, please do so. If you have glass doors, glass windows, if you have blinds anywhere, close your blinds. They'll act as a barrier, hopefully, for flying debris or glass. But try to get them in. Remember, red outlets are your emergent outlets. So if they're on anything that's electric that needs to be put into an electrical outlet and continue to run, they need to be in a red outlet. That is your backup generators. So that is what you want to do as a nurse. And make sure if they have guests, the guests don't need to leave. Everybody needs to stay safe, stay together. If you have issues with people, it's not for you to fight or battle. Please call security, hospital security, and they'll come and deal with a family member or friend if necessary. After an intense event, emotional shock can take place in those involved. So what can happen is you can be in emotional shock. And this is something we're really addressing anymore in the emergent setting. We're all about getting this fixed, getting that, but they're in an emotional shock state. And so it's so important. Heck, you'll be in an emotional shock state if you're working it. You can be. So what can happen, though, with your client or patient, they can have signs and symptoms of emotional shock, which include nausea, vomiting, and chest pain. With anxieties, people can have this. did mention this in class, and someone said, I said, what do you think you're going to see? And they go, an acute MI. And I said, yeah, you can see that with acute MI, but we're talking about emotional shock at this point. They're not having a heart attack. They're just having a shock that you really don't see. Nothing's going on, but emotionally, they're nausea, they're vomiting, they're having chest pain, they're having an anxiety attack. This is considered emotional shock. Usually it's not life-threatening, but can cause complications if the victim or patient has other medical conditions. If other things are going on, if you've got hypovolemia issues, volemic issues going on, and they're vomiting, that's not going to help issues, is it? So you do need to understand it's not life-threatening. Be in tune to it. But if there's other issues going on and they're also having the emotional shock, you need to treat both of it. You need to understand that. So just understand this could be happening. And if you compound shocks, it makes it worse. There are 5 stages that can occur: impact, heroic, honeymoon, disillusionment, and reconstruction. Those 5 stages are stages through emotional shock. So when it first happens and it gets all the way to where you're rebuilding. So in your mind, these things happen. They can take place, and you can go back and forth a little bit, but there are 5 stages. This is a review for the upcoming unit exam. The other thing I do want to remind you is to think about when we are transfusing volume. If you have a patient that needs volume and you have the big old clean utility cart and you see 500 different kinds of volumes you can give, there's not that many, but I'm just saying, like if you go to a grocery store and see the big, everything you can buy in the cereal aisle, there you are looking at volume. That's all great. You want to choose the correct volume to give for what's going on, but you can't give volume without an IV. So when patients that have had trauma, any kind, anything going on that it is life-threatening, you need to establish 2 large bore IVs. 14 gauge preferred, they say in the book. Most of the time what you see are 16s a lot if it's bad. 18 gauges are what we normally use in the ERs. You can use 14s, you can use 16s, they are there if needed. But I will say this about IVs. If you need to put a 14 in someone, really, if a physician is near, if you're in an ER or a clinic, hospital or a clinic, have a physician, ask the physician to place a line. You need it. If you need something that big, you need a line. I always get the question, if the patient is severely burned and there's no IV access, like both arms, everywhere you could possibly stick an IV is burned severely, would you put an IV in? Sometimes you have to, and it's just, you have to do what you have to do. But most of the times, if a patient or client is that burned, they will stabilize enough or maintain that patient to get them to the ER. And when they hit the ER, the physician can place a line. And that's what we set up for with trauma, is to put in those lines, because we know we need to have access to be able to give blood and volume and drugs to help this patient hopefully turn it around, and they will survive. I hope this helps.